Hello and welcome to the module Odo 570, the division of Endodontics. For those of you who forgot me, I'm Dr. Buchanan, and today we're going to be talking a little bit about outcomes of endodontics. Winston Churchill said, "Success is not final, failure is not fatal, it is the courage to continue that counts." Unless you poured these models, in which case you should maybe quit while you're ahead. Or perhaps made this special tray. Jokes aside, let's talk today a little bit more about root canal treatment, and let's just revise our goals. Our ultimate goal when doing endo is obviously to try and keep the tooth and provide our patients with long-term comfort, function, and aesthetics. And we do this by removing any infected or inflamed tissue from inside our tooth that may arise from caries, trauma, or other diseases of pulpal origin. The steps of a root canal treatment basically involve our access into the pulp chamber, isolation, cleaning and shaping of our canal systems both mechanically and chemical disinfection to remove all the irritants from the inside of the canal, and then to provide some kind of fluid-tight seal both apically and coronally in order to prevent reinfection prior to restoring with something definitive like a composite or a crown. And this all sounds very simple, right? In theory, these concepts that underpin endodontics all sound really straightforward. Basically, open up the tooth, clean it out, fill it up with something, and close it again. However, scientific evidence demonstrates that it's actually very, very difficult to do any of these individual steps perfectly. And I do at times think that it's a miracle that endodontic treatment works at all, never mind as well as it actually does. I always like to start with a case, so I ask you, is this a good root canal treatment? Have a look at it. I'll give you a couple of seconds. As we can see, there is a bit of a lack of a coronal restoration there. We can see this tooth has actually been filled with silver points, but the preparation seems to be quite a small taper. The canals are not filled all the way to the apices, but what is it that's interesting about this case if we look at it? Well, it's probably not a good root canal treatment, but when I examined this patient, the patient actually had no complaints. There was actually just a piece of the coronal restoration that had popped off, and it was sharp, and it was irritating the tongue a little bit, and they just really wanted a new filling. What we found is that there were no clinical symptoms on this tooth, so no periapical area, no periodontal ligament widening, the laminar dura was intact. It was functioning with the restoration until a small piece of it chipped off. And I want you to bear in mind that that root canal treatment was done 20 years previously, so it had really lasted quite a long time, and it was working. There was no problems with that endo. And then we get endos like these. So I did that root canal treatment on the left-hand side. I thought it was a really nice root canal treatment, but it wasn't even 6 months later or a year later, and the case had failed. And we didn't manage to retain that tooth. The tooth was extracted and an implant was placed. That's one of the 3 implants that I placed in my life, and the implant is still working. I still have long-term follow-up on it. But the point that I'm trying to make is that we can do nice endos, and those nice endos might not work. And that brings us to our endodontic outcome. So things aren't always as clear-cut as we'd like them to be, and whilst it's possible for us to have technically poor endo, which is successful at times, the opposite can also be true. Sometimes we have technically excellent endo, and that doesn't work either. And sort of despite our best attempts, some cases just won't work. And today, I'd like us to have a look at the outcomes of endodontic treatment and the factors related to either success and failure, and we'll discuss them all in more detail. The discussion surrounding success and survival is important because the criteria used to define success and or survival is not the same. So it doesn't describe the same thing. Success relates to whether something worked or not, and it's evaluated with a very specific set of criteria. This is in opposition to something like survival. Survival basically just measures whether a tooth or an implant or a bridge is still in the mouth. So how well does endo survive? Some of the classic studies, the first one by Selarabi and Rothstein from 2004, evaluated records. It was an epidemiological study of about 1.5 million teeth in more than 1 million patients. And what they found was that 97% of these teeth were still present in the oral cavity after 8 years. So that's the survival rate. Another study, more recent, by Burry et al., Journal of Endodontics, had a look at nearly 500,000 non-surgical root canal treatments, primary endodontics, and they found the survival of all the teeth that they looked at collectively at 1 year was 98%, 92% at 5 years, and 86% at 10 years. And what does all this tell us? It gives us a survival rate for endodontic treatments of approximately 90%. And whilst this sounds really high, you need to bear in mind that 90% is good, it's not a bad number, but 90% means that 9 out of 10 cases are going to work, but 1 out of 10 cases is going to fail. And how about success? So success is a different thing, and the assessment criteria when we try to define endo success is very, very strict. The first system was developed by Strindberg in the 1950s, and they looked at 3 things. So that was basically the history of symptoms, if the symptoms improved. They looked at objective clinical findings, as well as radiographic outcomes. And when using Strindberg's criteria, even a small periapical area was considered to be a failure. And that was even in the absence of clinical symptoms. So if on the radiograph you had a small apical periodontitis, the case would be considered non-successful when using Strindberg's criteria. So they were very, very strict. In response to this, in the 1980s, a new measure of success or a new system was developed by Ostervik and colleagues, and that was called the Periapical Index. And it consisted of 5 reference radiographs to which your case would be compared to, and then it would be considered either a healed case, a case that was still healing, or perhaps a case that was still in development. The Periapical Index is a better system, but you need to bear in mind that we need quite a long time to measure endodontic success. In some cases, I'll show you one in a future slide, require quite a number of years of follow-up in order to measure it properly. Here's the periapical index, so you can see that it's basically 5 reference radiographs, and you would then compare your radiograph of a case in front of you and determine where it falls on the scale. So in the first category, you can see normal bone, normal structure, no periapical pathology, and as you move through the scale to categories 2, 3, 4, and 5, at 5 we have severe apical periodontitis, so you would sort of measure where your tooth falls within the scale. And this is a very, very useful system for epidemiological studies. So how do we evaluate our endodontic success? It depends on our initial clinical situation. So it depends, was the tooth vital? Was there periapical pathology beforehand or not? Or was the case non-vital? Did we have a big lesion? And this will differ in terms of how we measure things. So if a tooth was vital and we did our root canal treatment, if the tooth remained asymptomatic and didn't form an apical lesion, then the case is considered to be a success. But if we started with a non-vital tooth that had an existing periapical area, we would have a look. Obviously, there'd have to be no clinical signs and symptoms, but we would also have to see some kind of healing. So the lesion needs to heal, it needs to get smaller, and no new lesion has to form. The American Academy of Endodontics suggests alternative terms to success and failure because they find failure to be a little bit of an absolute term. So they classify cases as being either healed, non-healed, in the process of healing, or perhaps a case that hasn't healed altogether but is still functional. And in order to determine sort of clinical and radiographic success, we need 6 to 12 months follow-up. But again, as I mentioned, complete healing can take up to 4 years to assess. So what do we have a look at when we're trying to define clinical success? We do a clinical examination. We're looking for no swelling or no signs of inflammation or infection, the absence of anything like a draining fistula or an isolated probing depth. Remember, periodontal probing is important to define endodontic success, and obviously a healthy soft tissue and normal probing profile around the tooth, and the tooth must still be comfortable for the patient and in function. Radiographic examination, we determine success by the absence of a periapical radiolucent lesion if we started with a vital case, or if it was non-vital and had a pre-existing lesion, we want to see a decrease in the size of this lesion and no development of any new lesions. According to your standard textbook, Endodontics Principles in Practice, it's recommended to follow up a tooth for at least 1 year following root canal treatment. It's important to realize as well that if we're looking at success rates, that non-functional teeth are automatically considered failures despite their radiographic status. And that makes quite a lot of sense because it doesn't help you've done a beautiful root canal treatment on a root of a tooth and that root is not bearing a crown and it's not in function. So even though it might be an endodontic success, it's not an overall success for the patient if they don't get function out of their tooth. When you do your radiography, try to get a relatively standardized image, so don't change the angulation too much. On the images that you take, try to get an image that's relatively similar to your preoperative image because that will give you better information of whether something is healing or not. And obviously your personal bias can play a role and it can affect what you see. So here's a case where I mentioned earlier that we need long-term follow-up. The radiograph, the diagnostic radiograph on the left-hand side, was taken 4 years before the radiograph on the far right-hand side. And you can quite clearly see that a number of endos had to be done. As I recall, there was some kind of trauma on this case. But you can see a very, very, very large periapical area on the left-hand side. And then after the initial treatment, there was some good healing during the working radiographs. And we followed up this case over a long period of time. And you can see that on the central incisor, we actually had very nice healing around the apical area. The canine was eventually endoed as well, and that also seems to have nice healing around it. But the lateral incisor still had a relatively large periapical area around it at the 4-year follow-up, and at that point it had been getting smaller over time. We actually retreated the central and the lateral incisor, but at that point, after 4 years, it stopped healing or the healing process didn't get any better, and then we referred on for surgery. Histological evaluation is probably the most accurate means of determining endo success or failure, but clearly we can't do histological analysis of every case. Why? Because in order to do histology, we need to do surgery or some kind of biopsy, and obviously this is not a routine option for assessing your endodontic outcome, so we stick to clinical signs and radiographic examinations. Let's talk a little bit about success versus survival. So root canal treatments are normally compared in terms of both success and survival to implants or fixed bridges. Success rates are not necessarily a valid comparison when you're trying to compare these things, though, because the criteria that define success are very, very different between, for example, implants and root canals. So it's a better comparison to have a look at the survival rates of root canal treatments and compare that to the survival rates of implants or fixed bridges, because that's a more realistic comparison. So survival rates look at our long-term outcomes, and as we mentioned before, most of our studies have found our survival rates for endodontic treatment to be in about the mid-90%. Implants have a similar long-term survival rate, and it's generally accepted that fixed bridges have a lower long-term survival rate than root canal treatments and implants. Well, let's have a more in-depth look at the causes of endodontic failure. So, failure can occur at any time during root canal treatments, and the factors are usually broken down into when these things happen. And that is preoperatively, operatively, so while we're busy doing the procedure, or something that happens afterwards, post-operatively. Let's have a look at preoperative causes. There are a couple, mostly misdiagnosis, errors in treatment planning, poor case selection, and treating teeth with a relatively horrible prognosis. And we'll look at specific cases now. Misdiagnosis in this particular case, not having enough radiographs. So this tooth was referred for a retreatment, And you can see that the distal roots seems to be a little bit underfilled, so there seems to be some bit of a problem there. If a cone shift radiograph was taken preoperatively, we would have seen that there was in fact two canals in the distal root. So a retreatment was done there, the missed anatomy was found, and then the case was successful afterwards. So always have a dead-on radiograph, especially for molars, and try to take some kind of cone shift as well to give you more information. Here's a case of vertical root fracture. That's also a preoperative cause of failure that leads to a misdiagnosis. But obviously, when vertical root fractures are in advanced stages, it's a lot easier to see changes on a radiograph or to see the fracture itself. But it can actually be quite difficult to see a microcrack on a radiograph, but very often root fractures are causes of failure, and they are preoperative causes. Here's a very interesting case, also misdiagnosis. So this tooth actually has a palatogingival groove on it, which is a developmental anomaly where the enamel and the cementum basically folds in on itself, and it creates a groove in the external morphology of the tooth. And the groove runs from the coronal aspect all the way down towards the end of the root. So this tooth actually tested vital. It looks like a non-vital case. It looks like this is a tooth that needs a root canal treatment, but when we did a pulp test on it, it was actually, and vertical percussion, this tooth was actually 100% vital, and it wasn't too tended to vertical percussion, but a little bit more to lateral percussion. And this tooth did not need a root canal treatment. It was actually referred on then to our colleagues in perio, and a flap was brazed palatally, and that granulation tissue is basically cleaned out, and that palatogingival groove filled up, and the case healed quite nicely without root canal treatments. So it's obviously a very rare case. It's a weird and wonderful thing, but this type of thing could lead to a misdiagnosis. So if you did just a root canal treatment on this tooth, there was very, very small chance, or basically no chance, that this tooth was going to heal, because the primary cause of that lesion was not pulpal in origin. And then what about something like this? Should we even do a root canal treatment here? This was a case that was actually referred up to the 5th year clinic. And you need to ask yourself beforehand, can we restore a tooth like this? Even if we do the nicest root canal treatments on these roots, can we put a crown on it? No, we can't. There's not enough structure left on this tooth. So this is a case that should just be an extraction directly. Then obviously things can happen whilst we're doing the endo itself. Mostly inadequate cleaning and shaping of some form. Anything that can leave bacteria or inflamed tissue behind is going to contribute to failure of the root canal, and that's a lack of straight line access, your procedural complications such as transportation, ledging, perforations, instruments that are separated, or either under or over instrumentation or obturation of the case. Inadequate cleaning and shaping, as we mentioned before, anything that leaves bacteria behind is going to be able to cause failure of our cases. A lack of straight line access, for example, in this case, left quite a lot of pulp tissue behind. In multi-rooted teeth, canals can obviously be missed as well if we don't have good straight line access. And if we find all our anatomy and clean it out and shape it properly and disinfect it, then we have a much better chance at getting success. We know from micro-CT studies and anatomical studies that even if we prepare our teeth quite well, if we're doing everything that we should, there are a number of fins, communications, deltas between canals, and root canal systems can be very, very complex. So these micro-CT images demonstrate that quite nicely. This is actually after preparation of these canals has been done. So the light gray areas that you can see in these micro CTs is actually debris that's left behind, debris and pulp tissue. So we do rely quite heavily on our irrigation, even if we clean and shape properly. To length, we have to irrigate very, very well to get all the debris out, and it's often very difficult to remove all of the pulp tissue from canals. Another operative cause of failure could be a poor coronal seal or a poor apical seal. We'll talk a little bit more about apical seal in a bit. We provide our coronal seal with a nice resin-modified glass ionomer before we put on a composite or some kind of filling or a crown. But we need to give something that will give us a nice, definitive, long-term seal. Otherwise, our bacteria from the oral cavity will be able to get back into the tooth, and that can clearly cause failure. Apical seal, also an important aspect, because we don't want any of the pathogens that exist within periapical lesion to get back into the tooth. Sealing of lateral canals, it's not quite as critical as giving a good apical seal and a good coronal seal, and this is mostly because our lateral canals don't connect directly to the oral cavity. Lateral canals usually do communicate with the periodontium though, and these can cause lateral lesions on teeth, and if we irrigate and disinfect well, you'll often see that you get a sealer puff that's expressed through these lateral canals, and it's nice to see. It gives you an indication that your tooth has been well cleaned and shaped, but it's not as important to fill them up because they don't communicate directly with the mouth. I want to talk a little bit about incorrect GP selection, because this is going to give you a poor apical seal. And how do we avoid this? Obviously, if we get a poor apical seal, as we mentioned, our irritants can get back into our root canal system. So always look for debris on the apical flutes of your finishing file. You guys are using the ProTaper Universal or the ProTaper Gold system, and so you can actually look for debris in the flutes. It's not applicable to all rotary systems, but for the systems that you guys are using, it definitely is. So when you prepare, look for debris on those last 3 flutes of the file. If there's no debris, prep the canal larger, and the matching GP that you should use should fit with tug back, but not only tug back, it must also have resistance to pushing the GP through. So you need to seat that GP firmly to working length, but you shouldn't be able to push the GP through either. In general, distal canals on lower molars and the palatal canals on upper molars have much larger canals, so it's very, very seldom that you're going to end on something like an F1 in these cases. You need to prepare it to a significantly larger size. I usually go as a standard for about an F3 on a distal of a lower if there's only one canal, or a palatal of an upper molar. These things obviously all depend on factors such as age, and secondary dentine formation over time makes canals smaller. So if you have a really old patient, if your patient is in their 60s, 70s or 80s, yes, there is a chance that you could even end in your traditionally larger canals with a smaller size. But in a young patient, you're very, very seldom going to be able to place an F1 GP into a palatal canal and seal it. You need to have a look at each individual case, gauge every individual canal and have a look, but a good way of checking that is to look for debris on the flutes of your files and then fit your GPs positively and get an x-ray and see, are we pushing it through or are we ending short? Transportation, ledging, perforations, obviously these are things that can happen whilst we're doing our root canal treatments, and it could be because we're not pre-curving our files, it could be because we're not checking patency, that we didn't establish a good glide path, and obviously these things can lead, your transportations and ledgings can lead to untreated anatomy, as demonstrated in the radiograph on the left-hand side. And the apical third of our root canal systems is where we have our most complex anatomy. So if we don't really adequately clean our apical third, those last 3 to 5 millimeters, then we can think for ourselves that irritants can be left behind and that can cause failure. Perforation, similarly, can create a port or an entryway for bacteria to get back into our root canal system. And clearly in a coronal perf, demonstrated on the clinical picture on the right-hand side, we obviously have a lot less tooth structure as well to work with. So this can decrease the fracture resistance of this tooth and then cause failures in terms of fractures. Separated instruments. That's sort of an interesting one, because there's always a little bit of debate around separated instruments. To me, it depends on when the instrument has separated. So if you've already done quite extensive cleaning and shaping procedures, let's say you've already prepared your canals to an F3 and you've rinsed with your sodium hypochlorite from your S1 to your S2 through all your finisher files, then that canal should be relatively clean. So if a small instrument were to separate, let's say while you were doing your very final patency check, it will probably have quite a low bearing on the case failing. But obviously, if the first file breaks off, so the image in the middle demonstrates an S1 that broke off just when cleaning and shaping started, something like that is very likely to cause failure on a tooth like that because you haven't cleaned and shaped the system yet. And obviously, in those cases, you want to try and remove them. Fortunately, we were able to remove that one. But separated instruments, it sort of depends on whether you can take them out or if you could bypass them. Because remember, if we bypass a separated instrument, it really doesn't affect our failure rates or our success rate very much. But obviously, if it is obstructing anatomy and we can't clean and shape, then it can lead to failure. Same can be said for under instrumentation. If you have a shortfall and we're leaving irritants and bacteria behind, the case can fail. This is well demonstrated in this particular case. Patient still had clinical signs and symptoms on this case because we can see that that last sort of 5 or 6 millimeters of the case was never treated. So an effective retreatment resolved all these symptoms in this case just because we removed the irritants that were left behind. The same can be said for an over-instrumentation. It can also cause failure because we'll have overfilling of the case. If you have a look in this particular case, radiograph on the left-hand side, there's a compromised seal, but that wasn't what was causing the problem. If you have a look at the angulation of those roots, you can see that there's actually a lateral perforation of the palatal canal, and it was filled through, and that through fill, the GP and sealer that was present in the bone and in the periodontal ligament space caused failure in this case. It was difficult. We retreated that root canal, but we weren't actually able to get back into the original anatomy. So what we did is we just filled it short and tried to stay within the roots. In this case, actually worked out quite nicely. But remember, anything that we extend past our root canal space can cause a foreign body reaction. That can lead to failure as well. And then post-op causes. Usually something like a lack of coronal seal, a lack of using rubber dam in the first place, any gaps or voids that are present, or your GP not burnt off to the correct level. If you don't get a really nice bond of your composites onto the walls of your cavity, that can also cause failure because it causes leakage of your restoration. And if you have done a really nice root canal, but you perforate with a post-prep afterwards, or creates a fracture, that can lead to failure. And even our bleaching procedures, when we do a non-vital bleaching, some of the materials that are used in bleaching procedures are thought to cause resorption, especially if you don't have a good coronal seal. Let's have a look at some specific post-operative causes. Lack of coronal seal, it's usually not a problem in South Africa because we teach you guys to restore the tooth definitively right after we've obturated. This is not true of all countries though, so especially in countries where endodontics is a specialty, very often the root canal treatment is completed and they actually place something like a cavit or an IRM and send it back to their referring dentist. But then often once the root canal treatment is completed and the pain is gone, the patient doesn't go back to the original referral because they don't want to pay more money, and then we can have leakage past that cavit or that provisional restoration. But that's really not a problem in South Africa because we restore permanently at the time that we obturate. Except sometimes when you run out of time. So this is a case of a friend of mine. I actually did this root canal treatment, but we ran out of time, and then at the end of the procedure we placed just a glass ionomer restorative material, basically as sort of like a semi-permanent thing, and he was supposed to come back just a couple of days later, but life got in the way, and after about 3 months time this case actually failed, and the patient actually had symptoms on this case again. So I had to actually redo this root canal treatments because of the leaking glass ionomer restoration. So glass ionomers, they're not good for a long-term seal, and you won't have this kind of problem if you restore the tooth definitively with composite. So in this case, I did the retreatment, placed a composite or built a core immediately because it needed a crown, and then I crowned it 2 days later to prevent that from happening for a second time. So it's okay to make mistakes, but do learn out of the mistakes that you make. And despite all of that, we still remain friends. Post-op causes, lack of rubber dam isolation. I think at this stage of you guys in the course, I really don't have to speak about rubber dam anymore. Obviously, if you don't use a rubber dam, you're going to have a chance of increased microbial contamination from the oral bacteria into the case. There's really no excuse. in modern times not to use a rubber dam. Remember as well, it's impossible to defend a case legally if you haven't used a rubber dam, especially if there's a procedural accident or an instrument breaks off or something gets swallowed or aspirated. As the old adage went with clientele life, don't talk to me, talk to my lawyer. You don't want to be in this kind of position, so always just use a rubber dam. Gaps or voids present between the restoration and the GP. These leave dead spaces, and any sort of gaps or voids can harbor bacteria or irritants. So we want to try and keep gaps or voids to a minimum, and that's why we try to do nice dense obturations. And we'll talk about that in the advanced obturation lecture in a bit more detail. It's important to burn off your GP to the level of the CEJ. If you've got a puncture that's extending all the way into your access cavity, this can serve as a route of contamination. Also, I mentioned before that you want to try and remove the sealer from the walls of your cavity. Remember, the sealer that you guys are using, and you probably use it in private practice as well, is zinc oxide eugenol based sealer, and the eugenol can affect the bond of your composites, which is why we don't place, for example, calcinol base layers under composite restorations. So you'll often find when you're burning off your GP that there's quite a lot of sealer on the axial walls of your preparation. Take some alcohol solution, some 70% alcohol, and actually remove that sealer prior to bonding and restoring the tooth, because if you leave sealer behind, it can cause leakage of your restoration and then bacteria can get back into your root canal. Post-preparation, sometimes you do a very nice endo and then things go wrong at the crown and bridge stage of it. I think I've shown you guys this radiograph before of the horrible post-prep perforation on a patient that I saw in 2014. I didn't do that post and crown that was referred to me. If you want to try and avoid procedures like this, I like to use a Gates Glidden first, a relatively small Gates Glidden, a number 2 or number 3, and then I remove my GP before I start working with my post rolls. And when I do a post preparation, I start with a small post roll and I progressively enlarge it. So don't go straight for a red or a black parapost roll. Even after you've removed the GP, remove the GP first carefully, start with a small post roll, and don't be aggressive. Another post-operative cause of failure is removing excessive pericervical dentine structure, and this can lead to fracture of the tooth. And this makes a tooth obviously weak in its cervical portion, and then it can fracture and break off easier. So you need to ask yourself the question, if you have a look at a case, how long will a restoration last if I do a restoration on this tooth? Can we crown a tooth? If you have a look at this particular case that I'm demonstrating, it's a little bit different though, because this patient was 14 at the time of presentation and was referred to me to try and remove that instrument. The instrument is not a file, it's actually a probe. I don't know how somebody managed to break off a probe in this tooth in a child, but they did. But in this particular case, even though we know it's not going to work for a long time, we know that the prognosis here is probably very, very poor, but you need to consider all the factors. Do you want to cut a bridge on a 14-year-old? It's not a good idea. We can't place an implant yet, she's not finished growing. So in this particular case, we had to make a plan. But obviously, if you do find that you have teeth with very little structure, as we showed in that molar earlier as well, you need to think very carefully about whether you're going to do root canal treatment in the first place, because a case can fail for restorative reasons as well, and that's still considered a failure. Another post-operative cause of treatment failure is bleaching. If you don't provide an excellent coronal seal, then your bleaching materials can actually leach out into your dentinal tubules. It has been implicated in cervical resorption. So try to provide a very nice coronal seal if you are considering doing non-vital bleaching procedures after root canal treatments. What options do we have available to us if primary endodontic treatment fails? We can do an endodontic retreatment via an orthograde approach, so basically remove our GP and sealer, re-prepare the case, re-disinfect the canal space and fill it up again. We can move to our surgical options, so something like endodontic surgery or microsurgery, like apicectomies and stuff. We can extract the tooth and replace it with an implant or a bridge, and then there are some weird and wonderful options like replantation or autotransplantation, or we can extract and do nothing, and we can cover this in a little bit more detail. Retreatment, the removal of your old GP and sealer, redisinfection, and reobturation. The success rates of retreatments can vary, And it depends on the study that you read. Some of the historical studies that are really old have very low success rates, and some of the modern studies have really high success rates. If you do it with modern approaches and modern materials, I have found that it works very well, but it's not just me. The literature supports it as well. Modern studies demonstrates about an 80% success rate if you can find the cause of the initial failure. So you need to identify, why did this case fail in the first place? So let's have a look at these radiographs. You've seen them before, but this case clearly failed because that apical 5 or 6 millimeters wasn't treated. So we actually managed to re-establish patency there. We got to the correct working length. We disinfected the entire root canal system, and this case worked. Endosurgery, things like apicectomies, it has changed significantly in sort of the past 20 or 30 years, and that's led to much better success rates. So these days, when endodontic surgery is done, it's actually apical microsurgery. You need magnification, something like a microscope, and ultrasonic instrumentation to do some kind of retro preparation and a retrofill with a bioceramic material, something like MTA. I want to mention about endosurgery that it's not a rescue option for bad primary root canal treatment. So you can't do a poor endo and expect that if you're going to do some apical surgery that's going to work. Endosurgery requires you to have an excellent retreatment beforehand, so you need to try and remove the bacterial load from the root canal system before you do surgery. But surgery works well because we're removing that sort of last apical 2 to 3 millimeters, and we know that's where the complex anatomy is. And if we have any extra reticular biofilms, so that's bacteria on the outside of the root system, surgery can help us to remove that as well. And longer term studies do demonstrate a high success rate for endosurgery if modern treatment protocols are followed. You want to try and remove your granulation tissue. As I mentioned before, retroprep your canal with ultrasonics and actually retrofill these cases with a bioceramic material, something like MTA. It's not good enough just to cut off the tip of the apex. Implants are an excellent option to replace teeth where endo is no longer possible. I don't think that implantology and endodontics are competing treatment methodologies. So I found that there's a very clear indication of where we can do root canal treatments and they can work. And there's a point where root canal treatments where endodontics is no longer possible, and then a tooth is better replaced with something like an implant. Implants are great. They have a really high success rate. They do use different criteria to evaluate their success, but they've got a really good survival rate as well. Some of the drawbacks of implants, of course, is that the cost is unfortunately high, and our implants don't replace our periodontium. So you don't have a ligament space, you don't have a pulp, you don't have dentine, and you do lose proprioception in this way. My belief is that natural teeth are still the best implants around, as long as you can have good long-term function with the case. So if you can't provide a good long-term prognosis for a patient with endodontics, I think it's always very reasonable to consider implants. They should always be considered and presented to your patient as an alternative treatment option. Remember, whatever treatment you choose, whatever you do, you have to be prepared to deal with any and all complications, however. So that's why I'm a bit more comfortable with endodontics. Fixed bridges, success and survival rates that vary between about 48 to 95%. So also there's a variable success rates, and it will depend a lot on your sites and your case selection. It's generally accepted these days that implants are a better option if the tooth does need to be removed, if we do have to do an extraction. And implants is probably generally a preferred option over a bridge in modern times, because when we do a bridge preparation, we obviously remove enamel and dentine on those teeth or on the adjacent teeth, but it really depends. If your two adjacent teeth are heavily restored, then a bridge might be an excellent option. Bear in mind as well, though, that even though implants are generally considered to be a better option, not everybody can have implants. So somebody who's been on intravenous biphosphonates at a high dose, for example, those types of patients can't have implants. And implants are definitely not for everybody. Some patients might choose not to have them, so don't throw away your fixed bridges. They are always an option, and it is an option that you can present to your patients. They do, however, in terms of scientific literature, have a lower success and survival rates as compared to root canal treatments and implants. Intentional reimplantation, that's extraction of a tooth, and basically where an apicectomy is performed outside of the mouth, and then the tooth is placed back into the socket and sutured into place. It's important if you're going to try an intentional reimplantation so that the tooth is not outside of the mouth for too long, so it shouldn't exceed 15 minutes outside of the mouth. It is extremely case selective though. This is not for your run-of-the-mill cases. It's often performed in cases where you have conical roots, so where you know you're going to be able to perform a nice simple extraction and get the tooth out in one piece. And it's often considered in cases where endodontic microsurgery might damage vital structures. So that's for example, a conical malar that's really close to your maxillary sinus or very close to your inferior alveolar nerve, where you might cause nerve damage or a sinus perforation if you're going to try and do an apicectomy in that area. So extremely case selective, but it is an option. Intentional reimplantation is an option. Autotransplantation, that's the transferal of a tooth from one socket to another in the same patient. The procedure scientifically in the literature actually has a surprisingly good prognosis. It's most often considered where you have a lower first molar that's failed and that needs to be extracted, and a nicely developing wisdom tooth, something like a 3/8 or a 4/8 that has about 2/3 root development. Then it's possible to actually remove the first molar and then take the third molar and actually put it into the first molar's position. If these cases do fail, it's usually due to resorption or ankylosis. Bear in mind, there are also cases where premolars have been autotransplanted to replace a central incisor, for example. Extraction without replacement. Remember, a shortened dental arch is always a viable treatment option as long as you have about 5 occluding pairs on each side. So basically from premolar to premolar occlusion. If you're going to consider these types of treatment approaches, always advise your patients of the consequences of tooth loss, that there will be drifting, over-eruption of the opposing tooth, loss of contacts which can lead to caries, and even TM joint disorders. It's a common request obviously in our posterior teeth because to patients their front teeth usually matter more than their back teeth, but it is definitely a treatment option if endo fails. In conclusion, endodontic treatment, root canal treatment, it's a predictable procedure with a high success rate and a high survival rate. Please bear in mind though, some of your root canal treatments won't work. So a 9 out of 10 success rate means that 1 in every 10 will fail. So you guys do, about 5-6 cases in your 4th year, and you're going to do 4 or 5 molars in your final year. So that means that out of those 9 or 10 endos that you're going to do, one of them is very likely going to fail, and we know that from the scientific literature, and we must expect that. It doesn't have 100% success rate. Endo doesn't work all the time. The causes of failure can be multifactorial or due to one reason, and failure can occur at any time. So it can occur due to factors before treatment, something that goes wrong during treatment, or something that happens after treatment. But don't feel bad if you have failure. Try to maintain your natural teeth wherever it's possible. Like I said, a natural tooth is still the best implant that you're going to have, and try to always choose the option that you would have chosen for yourself when dealing with your patients. It will help you to sleep at night. Prof. Becker always used to say it's better to sleep well than to eat well. Recommended reading. If you are interested, you can go and have a look at this article. It compares the long-term survival of implants and root canal treatments by Setzer and Kim. It's in the Journal of Dental Research from 2014, and it actually gives a really, really nice overview of this topic as well. Guys, thank you for your attention. If you have any questions regarding this online presentation, please do send me an email and let me know if you have any questions, and we'll deal with those questions on an individual basis. Thanks for your attention.